Bill Henderson, good morning. Well, why don't we go ahead? We got like 20 people, and I'm sure we'll have more shortly. I'll just say that I'm very pleased that John Lynch, who always gives us a talk, not on this topic ever before, was kind enough in the midst of a very busy life with COVID to give us a presentation. I titled it "My Life with COVID." He'll give it a more appropriate title, and hopefully teach us a great deal. So go ahead and take it away.
Thanks, Len, and thanks as always to this group, both you and Drew and really everyone for inviting me again. It's always a pleasure. I don't know whether this is year 10 or 11 for me in meeting with you guys, but it's always fantastic. And we find yet another way to make this work. What I'm going to talk about today is a little different than when I've done that before, where it's usually been a collection of things that I just find interesting, and often this group also does as well, and really focus on COVID-19 from, I don't know, we've all been insiders into this, unfortunately, and I'm just giving you my perspective since my involvement starting many months ago. I'm going to go through, there's a fair number of slides here, but some of them are pretty basic. And so I'm going to go over them quickly and give a little bit of a peek into what I think is the forecast, as Len was sort of alluding to, and then open it up for questions and discussion. If at any time folks want to ask a question or a point of clarity, I can't see everyone, so it's a little tricky, but if Drew or Len or anyone gets a notice, let me know and I'm happy to stop and make things clearer or answer a question. So for those of you who don't know me, my name is John Lynch. I'm an infectious diseases doctor. I've been based at Harborview now for 10.5 years. And I am predominantly involved with infection prevention and control, employee health, antimicrobial stewardship, and sepsis. So I'm really sort of a programmatic person. One way to think of it is sort of like public health on a campus or within facilities. And that's really where I focused my learning and developed some level of understanding. I'm hesitant to say expertise, but at least some understanding over the past 10.5 years. I work both here in Seattle at Harborview and across UW Medicine facilities, clinics, hospitals, Airlift Northwest and everything, as well as across the Pacific Northwest on a very large tele-stewardship program. It's actually larger than Pacific Northwest now. We go down to Washington, Idaho, Oregon, Utah, and down into Arizona. And then I also work in Kenya on infection prevention controls with a CDC-funded project with the Ministry of Health on developing infection prevention programs in their facilities. The thing that's always remarkable to me about hospitals is how just complicated they are. I'm involved in the nuts and bolts, where people come into buildings, where they leave them, where the air comes from, where the water goes, how we handle just a huge number of complex subjects. And as a result, I'm really part of a lot of teams that do a lot of incredible work. And again, for those of you who are new to Seattle, perhaps the fellows, this is a overhead shot of Harborview Medical Center, which is embedded right in downtown Seattle. We're part of a larger system. I also deal with, as part of this COVID response, more than ever, I've worked really at the leadership role with the COVID response across our facilities. So Harborview, Valley, Northwest, and Montlake campuses of UW Medical Center. And also working across our neighborhood clinics. I always forget the number, it's 16 or so neighborhood clinics. Drew knows the East Side Clinic. We have Northwest Primary Care Clinics. These are all separate, Airlift Northwest. Just a large number of sites and ways of delivering care, as well as the School of Medicine, which ultimately is embedded in this larger environment of the University of Washington, which has worked through its own arc over this, which I can certainly answer questions about as they've been in the news recently. For me, this story started back in the middle of January, so I'm going on to month, 7-ish, working pretty much nonstop on COVID-19. For those of you locally here, probably remember this headline with the description of the very first case of COVID-19 in the United States that was described. It was unlikely the first true case, but the first diagnosed case was here in Western Washington in Snohomish County. And this was obviously a huge deal, made the news. There's the governor and Secretary Weissman to the left. And I'm sorry, I don't recall the name. It's Dr. Pillai from the CDC there on the right with that response. It was a really aggressive response with this single person. He had arrived from the Wuhan area, I think around the 16th or so, with no symptoms at all. Subsequently developed some mild respiratory symptoms, was seen in a couple clinics, and through his own research was worried about potentially having COVID-19, finally returned and asked for a test, and that was done and it returned positive. He was moved immediately into Prov Everett, where he actually, his disease progressed, required oxygen supplementation, some other care, was hospitalized, I think, for about a week and a half before being discharged to his home. This was very disruptive to, obviously, our community and to his own family and to the patient. But one of the big things that came out of this was that there were about 60 plus, between 60 and 70 contacts of this individual. And it became quickly apparent to our public health colleagues in both the Snohomish Health District and Public Health Seattle King County that they didn't have the people to respond to all these contacts in the middle of flu season. So what happens if you're a contact of the first known COVID-19 case in the United States and you develop a fever or a cough or something similar? And this became a big problem, and this is really where I got involved early. Public health, that weekend after that first diagnosis, asked Harborview Medical Center to stand up a project that we had rolled out in the 2014 Ebola outbreak. That was our home assessment team. And this is a snapshot of our leader from that. That's Vanessa McCarowitz in the middle. And on the right is Chloe Bryson Kahn, who's another ID doctor, who's my partner in all this work, as well as Vanessa. They had reached back into their files and said, hey, can you guys do these home assessments? We said, of course, yes, got clearance from UW Medicine and started launching. This is actually us going to our very first home assessment within a week of that first diagnosis to evaluate. This was actually a travel case, not a contact case. This is someone who traveled from China to test a small child and an adult who had traveled from China and now had symptoms. We did this in their home. This is our vans backed up into a garage. And this really became a lot of activity for us in January, with between the contacts developing symptoms where we go and assess and do testing, and as well as rapidly involved into evaluation of travelers from high risk areas. It wasn't that long after until we got someone who was symptomatic and required evaluation in our emergency department. This is one of our nurses on the left and one of our hospitalists on the right at Harborview. This required, again, for our infection prevention team, balancing the home assessment work, our regular work, and then having to be hands-on and personally involved with working with you can't see off to the right there, the tattoos. That's one of our facilities leads, making sure that our pressure systems were all set in our ED, and making sure that the PPE donning and doffing were being done appropriately. This is before going in, making sure everything was there. And one of the big issues for us is that one of our small team had to be able to respond basically 24/7 whenever this happened, because the expertise on how to do this work was particularly around the PPE and really how people move within the room and how people come out and do this in a safe way. At this time, particularly with a brand new virus, was not widely understood. So we worked really hard. So 226, home assessment made its first home assessment. So this is fast forwarding about a month. We were called to see a patient who lived in the South Sound area. I forget whether it was Pierce County or King County, but someone had returned from Daegu, where it had a big outbreak. This was that church-associated outbreak in South Korea. We went to see that person. It was interesting in a couple of reasons. One is I went to see her, and at that point we had heard that it took about a week or so. People tended to get pretty sick, and we saw this person, and she looked all the world like the flu, 100%. She had a fever, just not that hungry, just tired, maybe a slight cough. I'm like, you have the flu. I'm sure of it. This just doesn't, the short duration of symptoms, just feeling uncomfortable, muscle aches, just the whole 9 yards. And so we tested her on a Wednesday. I think by Thursday, we found out that she was infected. And that was our first with COVID-19, with SARS-CoV-2, and that was our first travel-associated COVID-19 case. So it took us about a month before we made our first real diagnosis of a case, and it was our travel-associated case. So this is the week of 226. This goes down because we had a lot happened that last week of February, as I'm sure everyone probably recalls, or maybe doesn't want to. 229, we had learned earlier in the week about a 15-year-old, I think, who was diagnosed with COVID-19 as part of the Seattle flu study. So the Seattle flu study has done this community home testing, where people do their own swabs for flu, and we're able to do lots of really cool studies on that to look at the epidemiology of the entry of flu into our city. They decided to go back and actually test some of those swabs for SARS-CoV-2, and they had actually found this 15-year-old who had been tested and who had had no travel, no exposure to anyone, but was in that kind of North Seattle area where some of these, where that first patient had been, lived, and where some other concerning cases were maybe circulating. And so we were asked to go out and clear him. So that needed, at that point, 2 negative tests after a certain amount of time, and to test the rest of his family who had been quarantined in their home. This was very challenging for this family, right? They didn't want to be known as a COVID family at this point, given how few cases there were, potential community attention. They lived in a neighborhood which is very visible. And so we were asked to travel out to reduce the risk to, someone coming into a clinic or something similar, and test him and his family. We were hoping to get this done first thing in the morning and be able to have the rest of the Saturday off. And we went to his home, tested him, tested his rest of his family. His family actually got kind of upset because we had a couple of big white vans in their front and PPE, doffing in their driveway, and it kind of became obvious, unfortunately. But I think that worry kind of faded quickly, because later in that day, we learned that Dr. Frank Rito at Evergreen Medical Center had made the diagnosis of the first 2 community cases from the Kirkland Life Center outbreak. So these are, again, these are older folks who had a lot of comorbidities, were very sick, and had no travel and no contacts. And so that was sort of the next thing we learned that Saturday morning, that there was evidence of COVID-19 transmission in the community beyond this youngster. And then later that afternoon, evening, we learned of a diagnosis at one of our UW Medicine facilities, Valley Medical Center, of a patient who had been in their hospital, including their ICU, for, I forget, 4, 5, 6 days, out of precautions until the diagnosis was made, and so had a very, very large healthcare worker exposure that we ended up going down there and working up. And I think that day finished around 1 a.m. So that was 229, February 29th, Saturday. And we were pretty busy with the home assessment stuff, with the developing policies and protocols, meeting pretty much every day around how to set up these policies and protocols for travelers, especially in clinics, working on the PPE recommendations for people coming into our emergency departments who are being hospitalized. The testing at that time was really hard. It's hard now, but it's way harder then, because it was only, you had to send it to the CDC. It was extremely limited in terms of the case definitions and who could actually get tested. It moved this week of this 229 week to the Shoreline, to our state lab. And actually that first travel case was number 1 to be tested in the lab. So we had a little bit better access, and we were lucky because of these community cases that Frank diagnosed at Evergreen, but it still wasn't super easily available. So that was basically, since that time, that day, it has been pretty much 7 days a week nonstop working on COVID-19, and kind of my old job was put on hold. And I've been doing my new job, which is basically COVID-19 clinical leadership for UW Medicine since. That next day, given those exposures, the evidence of the community transmission, what was going on at the Kirkland facility, UW Medicine leaders decided to stand up our first ever UW Medicine Emergency Operations Center. And at Harborview, my facility, we stood up our Emergency Operations Center as well. And the idea here was that each of the medical centers, Valley, Montlake, Northwest, stood up an EOC. They had their own representatives planning operations, logistics, comms, all that sort of stuff. incident commanders at each site, and then they would report up through the UW Medicine EOC. That was the first time we had ever done that. And so it was really interesting to get it going and make that decision. It was a big decision on that Sunday. And we basically turned it on the following day. One of the things and the biggest actions that took place on that day, besides the development of that EOC, was that the UW Clinical Virology Lab folks have been actually working on a SARS-CoV-2 test since January. They were really forward thinking and had worked extremely hard on getting FDA approval for this test. And I think got an EUA approval in the day before, literally just working nonstop for a week with the paperwork, literally faxing, I think 24 hours a day, huge piles of paper, and get it approved. And on that Monday, again, fortuitously, we were able to actually start doing UW Medicine SARS-CoV-2 PCR testing within our facilities. And that evening, so that day we started the EOC, and so within a few days of recognizing community transmission was going on, we started testing all patients who were being admitted with respiratory symptoms, which was a huge win for us in terms of being able to protect our patients and our workforce. 3-2, here's actually 2 members of our HAT team. I don't remember the person's name on the left. She was one of our nurses who was helping us part-time. And then a person on the right is Krista Rietberg, who's one of our infection prevention team. And just, just again, the highlight, if you guys think about how many deaths and infections we've had in the United States, and this is going back to, I think, February or beginning of March, second U.S. coronavirus death in King County, more cases likely. Just sort of a throwback photo of this. The Kirkland outbreak during that week was huge in the weeks following. I mean, I can't even speak the devastation to the patients and the families and the workers in that facility. So I'm going to not talk about that because I don't think I'm capable of addressing it. But what I do want to talk about is the response. There's this thing called the Disaster Medical Coordinating Center, which is run out of Harborview, which is really about how you spread out and level load patients from disasters. So if there's a huge trauma, big fire, something like that, an earthquake, how do you move patients from a site to a bunch of hospitals? And so we actually ended up setting up the DMCC that week. And so the Kirkland outbreak was basically was a disaster within the larger disaster of the pandemic. We also started working with the Northwest Healthcare Response Network. We are very fortunate in Western Washington to have a longstanding health system response network. That's the Northwest Healthcare Response Network that coordinates and cooperates across Western Washington to have frequent meetings, transfer of information, data sharing, and planning, and also work as an intermediary with the Department of Health on many key issues that came up over this, particularly the crisis standards of care models. We also recognize, as I mentioned, that Valley outbreak involved a lot of healthcare workers. I forgot the total number, but basically we learned that Sunday, the day we're deciding to set up the EOC, that we had a patient at Harborview the prior week who had died, the Tuesday before, who had died with a sepsis-like syndrome. He was actually transitioned to comfort care in our ICU after being there for about 2 days. And he had had no positive cultures, but he had come from Life Center. And someone on the team recognized this series of deaths being reported at Evergreen, which had really ramped up in numbers over the subsequent days, and that the fact that this guy had came. So we made the epidemiological link, assumed he was a presumptive case. We got a post-mortem test on him that came back a couple days later, but basically found out that he had actually died before the first death at Evergreen. And subsequently, there's another death that was reported before that, and there's probably deaths way before we knew about this in our facilities. And as a result, we had very large exposures to healthcare workers that we needed to deal with. And this is our first go around with setting up a testing facility specifically for healthcare workers at Harborview. This is a corridor which we shut down, and healthcare workers would drive to the back of the mailing building. For those of you familiar, it would walk through, be escorted through by security, a corridor out to this place. It would go into a prior conference room that we had made negative pressure. and they would get tested there. And this was, again, in addition to being able to test all respiratory tract infection patients who were being admitted, the ability to test healthcare workers who were exposed, especially those who had symptoms, was enormously helpful for us, because that allowed us to get a sense of what was happening in terms of transmission dynamics, and obviously provide support for our healthcare workers. So a lot was going on this week. This is just a snapshot of one of our anesthesia colleagues doing the first intubation in our ICU. You can see just the level of PPE, the big drape. Again, at this point, this virus had only been known for about a couple of months, and how it moved and all these sorts of things was still a little unclear. This is using a video fluoroscope and essentially doing it by himself in the room. So I just got a quick snapshot of that in one of our ICUs. This is our ICU 2 West Center. For those of you who've been up there, we have a 3-pod neuro ICU, A, B, and C. This is C pod. And because of our work at Ebola, we basically quickly had to transition this from neurosciences ICU to a COVID ICU. And just with the number of cases that came in over the couple of weeks, we basically ended up shutting down 2 of the pods and making the NICU basically a COVID unit for ICU care. And we decided to really focus a site and a team for COVID ICU. And we did the same thing. I think I have a picture coming up of our acute care floor. Here's a picture on the left of our ICU. You can see this went from sort of our normal ICU doing a lot of trauma and stroke to being a COVID ICU. We had these blue squares where people would have to stop and do their doffing procedure. We had all this monitoring. We had these trained observers who would do that, also known as doffisters, who would monitor that to make sure that healthcare workers are safe in the removal of their equipment, which is honestly the biggest risk. All the equipment at the bedside, at the door side. On the right side is 4 East, our acute care unit. And this basically became an entire floor for COVID as the numbers increased. Here's just a snapshot of some of our healthcare team at that point. This is again back down in the ED. I will point out what became known nationwide as COVID socks on these individuals. And part of our home assessments, we were out in these garages and hotels and all kinds of unconventional spaces. Vanessa recognized that our scrubs were dragging, and she said that's a contamination risk. So we had to roll them up or tuck them into our socks. And that became part of our normal training process. And it became actually sort of a team building exercise, an emotional way to express some individuality. If those of you on Instagram, you can go to COVID Socks and see just the incredible display of individuality with socks, because you'll see our nurses often are wearing their scrubs tucked into these high socks as a result of this. I'm not so sure how important it is for infection control, but it is a nice sort of nod to being part of the team. We also recognized over the course of that week, we made a huge number of policies, brand new policies. As of, I think this week, we're at policy something 76 that's COVID specific. And we recognized that this was not going to be limited to Washington State by any stretch of the imagination. And so within a week, we decided to make public all of our policies so that other health centers, both in the United States and across the planet, wouldn't have to waste their time writing policies and could just take ours, reword them, put their hospital at the top of it. And we published that within a week, basically. And we continue that to support that. Not every single policies from our internal site is on the public site, but most of the important ones are there. And we've since heard just, a lot of very positive things about this and gratitude so that people, again, don't waste their time. Here's a snapshot of some of our ICU nurses. Again, we decided to focus a team for both acute care and ICU. And these guys were just absolutely amazing in the midst of this whole outbreak. Just the huge number of patients, the complexity of care, the number of deaths. That Kirkland outbreak was really devastating, as I said, to the families, the patients, the healthcare workers who, again, I could spend an hour talking about that outbreak. But these folks came in very sick, and many of them died very quickly and often died alone. It was extremely hard for everyone involved. And I just want to give a shout out to the nursing team and the ICU teams on this work, being, again, 2 months into this brand new disease and just doing incredible work. So a little bit of public health and governmental stuff. For those, again, who are here, March 11th, so a couple weeks into this, our first restrictions started. So the any gathering restrictions began on March 11th. On March 13th, schools all of a sudden were going to close. Actually, in Seattle, public schools closed on 3/11. It was a Wednesday late afternoon, and they basically just said, we're closing tomorrow. And you can just imagine the potential disruption that we were anticipating with lots of healthcare workers having children who they depended on that school, not just for education, but for daycare, was a huge issue for us. Fortunately, we were able to mediate it, and the parents actually mediated most of it somehow. But that was a big deal, pretty abrupt as a parent of two school-age children, two middle schoolers. It was a huge disruptive event. 3/19, the governor said you have to cancel non-urgent surgeries and procedures because this was really the most effective and fastest way to make space in hospitals. And that was really one of the biggest issues that I think people had to get their brains around, is that we needed to restrict movement in society to maximize physical distancing in order to, as I think everyone knows now, but was a pretty new term back then, which is flattening the curve. And the reason we needed to flatten the curve was really two reasons. One is we needed to slow down admissions to the hospitals so they don't get overwhelmed. And we needed to give public health time to be able to respond in traditional ways. So contact tracing, testing, quarantine, all these things that are really important. It was very clear at the very beginning that public health was completely overwhelmed. I do not blame them. That is a result of us as citizens not supporting them and funding them, particularly since the 2008 recession. It's really been a terrible situation for public health around the country, from the federal to the local levels. But around this, we recognized, and everyone, I think, got on board pretty quickly, that the fastest way to make space was to cancel non-urgent surgeries and procedures to free up those beds. And it worked extremely well. 3/23, the governor issued the stay-at-home order. So that was, about 3 weeks in. 3/25, all the non-essential businesses were closed. And this is a snapshot of our EOC. So basically for, I don't know how long it was, this was probably 4 weeks in. That's Dr. Jihan Budek, who's an infectious disease doctor. She's really an HIV specialist. I mean, she does all ID, who was basically seconded to our team to work on employee testing because we had to ramp that up and open up a drive-through facility. So she went from being pretty much helping to run an HIV clinic and see HIV patients to setting up an entire employee testing site at Harborview. And this is in our emergency operations center back when we were still gathering. And that's Dr. Nandita Mani on the right, who is an infectious disease fellow who is working with our team in infection control and antimicrobial stewardship, who basically, when we had that first exposure, I turned to her and said, you're in charge of exposures. And she just took off and just did remarkable work. And this is just gives you a sense of little snapshot in, I don't even know what time of day this was, but we were basically, the entire team was working countless hours in this room. I don't think I can ever go in this room again, just spending so many hours through days and nights and eating way too many carbohydrates. I hope never, ever to have to go in there again. But the amount of work and the amount of people who were shifted over to this work was just astounding, especially as we shut down things like clinic visits, these non-elective procedures. It freed up a lot of people. And that's come back to become a big issue because all those people have gone back to their jobs now, despite a rising number of cases. Here's our first drive-through testing. This is actually the front door of our hospital until we figured something out. You can see folks setting up, people still not wearing masks, which feels a little weird and awkward. And there's our testing team on the right, just incredible teamwork. 3/16, all businesses were closed. And this is I think, just a snapshot from IHME, so the Institute for Health Metrics and Evaluation, which is part of the University of Washington, was started producing forecasts. People can argue back and forth. Again, I could spend an hour talking about models versus forecasts. But this was a snapshot from early on, looking at all beds projected needed for the COVID outbreak. So if you go back to March 1st, that purple line, the green line is ICU bed availability. and this purple line is all beds. And you can see that we went well beyond, the projection was to go well beyond the number of beds available for UW Medicine and Western Washington as this thing progressed through April. Fortunately, that didn't come to pass because we made all the right moves, but this was sort of what we were looking at this time and sort of lent itself to a lot of the desperation. One of the other big things that we did was try to create more environmental controls to prevent risk or decrease risk to healthcare workers and patients. And this is our emergency triage tent. And basically the way this worked is that anybody who would walk up to the emergency department entrance, which is on the far end of that, would be triaged outside. If you were walking, talking, and you had any respiratory complaints, you'd be triaged into this tent where everyone was in PPE. You were well over 6 feet away from the next person through barriers. There was an x-ray machine in there. You could get that type of care and be discharged without ever setting foot inside our hospital. This was really great. And the ER actually diagnosed more people with COVID-19 in this tent than inside the emergency department while this thing was standing, which was really, really effective. This is just a snapshot of some of the stuff that we did within our ED spaces. We recognize that our ED at Harborview is a lot of curtains, really tight space. It's a lot of little nooks and crannies. It's really poorly designed. And we needed to create additional barriers between healthcare worker workspace and where patients are seen. And this is just one of those attempts. So that's generally just an open desk where you can see all the patients who are directly across that blue line. And we put up these sort of temporary barriers, which our facilities teams had sort of pioneered back in the 2014 Ebola outbreak very effectively. We had a lot of team building. This is a bottle of wine someone gave me, one of my, I think, urology surgeon colleagues. Managing COVID is a balancing act, bringing together very characteristics of a seamless, unique health system is a challenge. From chaos comes balance. Let's hope so. I think anyone who is part of healthcare recognizes just how all in everyone was and how supportive everyone was that helped us get through some of these really, really tough times. This is, again, here's our COVID socks. We had a COVID day. Again, this is pre-masking in our facilities. That's Rick Goss on the left wearing COVID socks. And that's Jerome Dio, who's our chief nursing officer, who's doing doffing officer work, our trained observer work on one of these days. This is a respite plus clinic. So basically patients who came in who needed ambulatory care, diabetes care, cardiology care, whatever. And you had respiratory symptoms, you would be triaged to this tent, again, where the staff was really well trained. And this was actually an entrance into a clinic on the inside, but the waiting room was outside with good ventilation. And this was, and also for patients who were discharged with COVID, who could be followed up in the ambulatory setting. This is actually since still in existence. We don't have the tents up, but the Respiratory Plus clinic is still there. We went on to formalize a lot of our infection prevention work, which is, taking a lot of my time as we learn more about the biology of the virus, and try to make sure our workforce understood what we were doing, ranging from hand hygiene, how do we use physical distancing, how do we use PPE, laboratory testing for patients, for healthcare workers, a lot of education and communication, everything from sending messages out weekly with numbers to the town halls. For those of you who haven't been part of those are really amazing, led by Trish Critic and Ann Browning from the Dean's office. Very early on, I thought they were kind of going to be a waste of time, but have proven to be absolutely crucial to be able to answer people's questions and just, be very transparent in working with our EVS colleagues in environmental cleaning. So we've used this. This is basically our UW Medicine Prevention and Control Bundle. We've got a lot more details, which I'm not going to talk about right now, underneath all of these, and they all continue to evolve. This is our healthcare worker safety toolkit. One of the big changes that we've really experienced is this cultural transformation. I'm not so sure it's complete, but we're working towards it where, as healthcare workers, we're used to coming to work sick, and that is just a no-go. That is not acceptable anymore, given the subtle and varied symptoms of COVID-19. We can't do that anymore. And what's really good for us is we have easy access to free testing for all employees. And we've always had enough PPE. And in part, that's because we recognize based on our past experience and our expertise within our group, that this virus really moved like a lot of other coronaviruses and like flu, and we transitioned to using surgical masks for the care of acute care patients who are not getting aerosol generating procedures. And very early on, and as a result, we were able to maintain very good levels. I mean, lots of work was involved, but very good levels and adequate amount of PPE throughout this entire pandemic, and we will continue to do so. And have plenty of N95s and PAPR hoods and similar for patients in the ICU and for aerosol generating procedures. We hit our peak census beginning of April, 122 for our system. Harborview peaked at 32 in 416. 5-1, recognizing this is when people start talking about some reopening, people moving into the community, we decided that we needed to move to universal masking as a layer of protection. The physical distancing worked extremely well to keep healthcare workers safe. But as that physical distancing reduced at the beginning of May, we recognized that protection was no longer going to be there at the same level. And so wearing masks throughout our facility was going to be really key. And fortunately, I think pretty much everyone's come around to this in the community as well. And the CDC's behind it now. And even people in the White House, surprisingly. 518, non-urgent surgeries and procedures resumed, and concurrently clinic visits started to pick up again. Again, this is why we're really thinking about that masking in preparation for that. As more people coming into our facilities and traveling. And so it's really been dealing with sort of that dance of things since then. And so I'm going to go quickly into some of the numbers, and then we can certainly talk about some of the questions you may have. This is a snapshot of all UW Medicine inpatients. So you can see that peak of like 122 back in April. The dark blue is ICU, the light blue is acute care. You can see a lot of these ICU patients were here. A lot of people on ECMO/ECLS. A lot of these ICU patients stay in the hospital for a long time. And we had this sort of a little bit of breather back at the beginning of June. And then as we moved in Western Washington, King County, from phase kind of 1, 1.5 to 2, and people started going out, businesses started reopening, we've really started to see an uptick in cases across the county. We've seen, obviously, the wave of cases in Eastern Washington, which is now reflecting back to us. And you're starting to see an increase in hospitalization numbers within UW Medicine, both in the ICU and acute care. This is just a quick snapshot of where we are as of yesterday in terms of our beds. And so, the hospitals are moving along briskly. Harborview's back up to over 100% full, which is a big issue for us. And we're working very hard because that's a big problem when you're trying to think about ED throughput, the border situation. And you can see that, the rest of our facilities are in the 70s to 80%. Again, this is gonna be a hot topic of what proportion, we can do normal business as inpatients when we have COVID mixed in there. Here's an interesting graphic that looks at the distribution of age groups for folks in our hospitals. And so the greener numbers are folks who are in the older age range, and the bluer numbers go down. And what's really, I want to, really compare and contrast is that early in the epidemic, you can see week 14, well over half, 2/3 are folks in their 60s, 70s, and 80s. And part of that, it had to do with the fact that the skilled nursing facilities are being hammered really hard before that got under control. And again, there's been a ton of work in those places that UW Medicine has participated in across the state and helped with. And so that's certainly part of it. But what we're seeing is that this big, you can see now on the far right, weeks 27, 28, and 29, that what we're looking at here are people in their 30s, 40s, and 50s are the predominant folks who are in our hospitals right now, which is a big shift, but is reflective of what we're seeing in terms of transmission in the community. The biggest number of people getting infected in the community are from ages 20 to 40. And what we're seeing is that 30 to 40 and 40 to 50 decade or years coming into the hospital, some proportion of them ending up in the hospitals for care. And that's just, that sharp point of the spear for all the folks ending up in clinics and urgent cares and similar. This is King County data from yesterday, looking at the absolute number of cases. I'll always like to point out that these data are really tricky to interpret because it's based on lots of things, access to testing, where the tests are, and so forth. But let's just look at it just in terms of broad directions and slopes. Also point out the last 6 days in this gray bar on the far right are incomplete data. So those data still coming in from the prior 7 days to King County Public Health. So here's back in our peak, 221 infections on a single day. And over the last, 6 days, we've seen 192, 180 something, 180 something, 170. And as more data comes in over the next couple of days, I suspect we're going to still be there. And so here's the early June number of cases. And what we've really seen, and I think worries my public health colleagues, as well as myself and our team, and I think everyone, is this big increase in cases. Again, mostly people in their 20s, 30s, and 40s who have sort of returned to the workforce, are moving around society, are not wearing masks and going to bars and going to barbecues and weddings and other activities. I also want to touch base on this incredibly central and important topic of just the gross and crude disparities, inequities that this pandemic is highlighting. I think people have seen this in the media, but here's just a great snapshot from our own county. The way this is set up is it looks at basically the percent of cases compared to the percent of King County population. So let's start at the top. So 58.7% of people in King County identify as white, but they constitute 40% of cases. And let's just go down to Hispanic, Latinx. 10% of people in our county identify as being a member of one of those two communities, yet are 27% of cases. So basically a threefold greater risk if you're a member of one of these two communities or both. Similarly, you can see disproportionate impact on the Black population and the Native Hawaiian Pacific Islander population, which is extremely problematic for a number of reasons, not only because of the inequities, but also these populations, and especially those with limited English proficiency, don't have the same access to testing that a lot of other folks do. So we don't even fully understand the extent of the epidemic in these populations. This is a King County map showing the density of positive cases by reporting area. So just to orient folks, especially those of you who are new to the area, I'm not sure if you can see my arrow, but where it says Bremerton, if you go directly across, that's downtown Seattle, in that kind of aqua color between the two bodies of water. And as you move south towards Tacoma, you see darker colors. So we have two things going on here. Where these populations are being tested, they have higher rates of infection. And you don't see it in this map, but there's also less testing going on. So we don't fully understand the extent of the outbreak in the South King County area, which is extremely problematic for the residents of that area and our community members. Really problematic. At a larger setting, here's across the county, across the state. These dark blue counties are where you're starting to see higher rates of, above 2,500 cases. You've heard about the Yakima outbreak. That's this county in the middle, the Benton and Franklin County outbreaks. And what we're seeing now is spread upward to central Washington into the Wenatchee Valley, up into Okanagan, over to Chelan, which are small rural counties, aside from Wenatchee, and don't have a ton of access to healthcare. These are all critical access hospital-supported facilities. And the percentage of positive are extremely high, particularly in the migrant agricultural worker populations. Again, like Yakima, in the 20s and 30% range. So 1 out of every 3 people getting tested is positive. And this is going to, again, create a big problem for not only these communities, but for us in the state going forward. So quick projections. So this is from IHME where we are now. This is looking at deaths. If we wear masks going out into the future, that's this green line. You can see it sort of flattens out. So that's good, right? We're going to have more deaths. 100%. That's inevitable. But we're not going to see, if we all are good about masks, we can potentially blunt that. If we don't do it, and this is actually happening in a lot of communities, both here in Western Washington and in Eastern Washington, it's that kind of orange line going up. And so we're going to start seeing, especially as we move into the fall and into the flu season, we're potentially going to see a big increase in deaths, as you can see by that slope. This is look at daily infections and testing, the same thing. If we're going to hopefully see that green line. If the public is being good about masking, we're going to see this decreasing case in number of infections. We have not seen that right just yet, but hopefully over the next couple of weeks, as people adopt mask wearing and really focusing on the prevention mechanisms. But if we don't do something, if this does fade away in the fall in terms of our adherence to this mask wearing, you're going to see that orange bar, the line going straight up again with new infections, which is what's going to contribute to that change in slope for daily deaths. From my perspective, as someone who's focused on hospital resource utilization, fortunately, you can see, remember that bar I showed you with the big number of beds back in April? That never happened. We always had enough beds in our area, which is great. But as we look back into the future, as we look forward into the future around this and the overlap with influenza and other activities, schools and so forth, the forecast, could be significantly problematic. Now, the cognizant rules are very big, but we're going to see something.
Look at that,
It's going to be a large amount of work for us going forward. I'm not going to go through all these, but I do recommend taking a look at, this is the U.S. data, which is going to, again, be problematic. And, Washington's some of these pieces there, but the fall is really where we're looking at big problems, particularly if we don't adhere to masking, and we honestly don't know what's going to happen with schools. So lessons learned, I'm not going to go through all of these. It has been an incredible 7 months, a lot of learning, a lot of excitement, a lot of good stuff has come out of it. It has also been extraordinarily painful to patients and communities, to everyone on this call. I mean, I've never gave a talk to this group where everyone on the call has been directly impacted by the thing I'm talking about. And so it's just been a totally interesting, different perspective. We have done a good job, I think, of being able to handle this. We have a lot more to go going forward. I don't even, know what next week holds, to be honest. But we're going to see more cases in the near future, and even more so in the distance as the fall season comes toward us. So with that, I'm going to stop. It's 7:47. I think I'm allowed to have questions. I'll turn it over to Len. I'm going to stop sharing too, so I can maybe see pictures if people have them up. Thank you.
John, thank you. I had a question. I think you answered it. I was wondering very early in the outbreak how you had testing, and I guess that was back when the CDC was the only place that had a test, and it was a flawed test at that.
Well, the test they did at the CDC worked. The issue is that they had a very strict case definition, so you couldn't get everyone tested who you wanted to get tested. So that was one. The turnaround time took a while. You had to send it to Atlanta. Then we got the test kits got sent, or the test got sent to the state labs, including our Washington State lab in Shoreline. And the problem was that they were contaminated. They had a bacterial contamination in them. And so they probably could have worked, but not optimal situation to have a ton of bacterial DNA in your assay. And so that was problematic. And so that delayed things as well. And then once they got online, it only about a week later is when we turned on the UW lab one. If you can go back a little bit further, though, one of the biggest problems with testing in the United States, and among there's many, one of the biggest, I think, flawed decisions was that the fact that there was a decision early on for the CDC to make its own test, which didn't need to happen. Other countries had developed tests, which were very effective. And so instead of just adopting those, the US went alone and had to develop its own test, which led to additional delays.
This is somewhat of a political question, but as you look at the world's response and you look at our response and how hard you've worked to make King County's response excellent, what you're feeling about this nation as a whole?
Yeah, I don't think it's a political response. It doesn't really matter who's in that seat in my beliefs about other things. I think it's unequivocal that the federal leadership of this response has been a disaster throughout. There's really nothing you can point to that's been effective. And it definitely has political components, right? Leadership and so forth. But the access to testing the way it's been set up and really deferred to states to fend for themselves, to find PPE, to really compete against each other. I mean, N95 masks before this all started were about 50 cents per. Within a couple weeks, they were going $13 per, and they've gone more, right? And that's not possible. And what really drove that to some extent was not only the global supply chain, but the fact that, you know, Washington was competing against California, was competing against New York, was competing against, you know, the next state for swabs, for masks, for gowns, you know, on and on and on. And that didn't need to happen at all. Like, just that one thing didn't need to happen. There was also just the lack of access to testing and the ability to ramp up testing access across the country in an equitable and fair way was also, you know, part of that failure. And yeah, I don't think there's no arguing about it. The gap in federal leadership on this has been, it's killed people. I mean, it's killed a lot of people. And it's made a lot of people sick, and it's been incredibly disruptive. And I'm not pointing to the CDC on this. I'm talking about our leaders.
Yeah, I know. The other thing I've wondered about is China's numbers. I don't know that we don't get numbers from China anymore. They stopped reporting, or they've wiped this disease out. You know, considering it started there.
Yeah.
And they reported like under 100,000 cases in the end, and we're over 3 million.
Yeah.
What's going on there?
Well, I mean, I think that they have, you know, different response and different powers, right? So, you know, there's a variety of things, and we're going to be talking, you know, people who do epidemiology and public health at global level are going to be talking about what happened in China for a long time. And, you know, we have to be clear that we don't have full insight. We don't have full visibility into everything that happened there, including data, and sort of the tempo. But, you know, they have a lot of tools. I mean, a great thing about being an authoritarian government is that you do have an all-of-government approach, and it is one way or the highway. There is no highway. It's you are on board, or that's it. And that worked really, really well. I mean, they were able to get a hold of the Wuhan, Hubei outbreak, and they've been able to handle a lot of the outbreaks in other parts of the country. But, you know, to be honest, I haven't been paying that much attention because, you know, our approach has been on fire in the United States, and it's kind of distracted me from looking at other countries. But I think that you look at Italy, right? You look at even like some of the state responses in the United States, you know, New York, Massachusetts, and the way they've been able to handle things compared to what's going on in Texas and Arkansas and Alabama and Georgia and Oregon and Utah and Boise and all the other Texas, you know.
This is Mary Lasley. What are your thoughts about the kids going back to school in the fall?
Yeah, so I am not an expert, to be absolutely clear, on how this works. But I would say it is very problematic to send kids to school like right now. Like with our numbers going up, I don't think it's a good idea. And the issue is that kids get infected. Kids transmit, I don't know how much, you know, there's that paper just came out saying that kids get infected at kind of normal rates, they transmit at normal rates, but they don't get sick, although some do. The issue is that, like hospitals, right? I mean, like all of our facilities, there's a huge support staff. It's teachers, it's cleaners, it's, you know, lunch people, administrative staff, who, you know, are a segment of the human population with comorbidities and different ages and risks and so forth. And so in addition, we've built a public school system, like public health, underfunded and overcrowded with old buildings, poor ventilation, and too many kids per classroom. So how to physically do physical distancing in a well-ventilated facility is a huge lift. I can't even think of the trillions of dollars needed and the time needed to upgrade facilities to meet the space and ventilation needs that I think are obviously critical to that. And so I'd say that you kind of put that situation into the context of a rising number of cases in King County. I don't think right now you could open a school. maybe I don't know what it's going to look like in a month. And so things may change, and probably will, but it's going to be a big problem. So if I had to put a nickel down right now, you're forced to, again, recognizing things could change in 4 weeks or 6 weeks. I'd say right now, January looks a lot better than September.
Thank you.
Sorry.
Oh no, my kids are grown. I'm okay.
Okay. And I got 2 middle schoolers, man. This is not cool. It is a problem. And I recognize how terrible it is, but I don't know how to make it work.
John, I know this isn't your expertise, but do you have any insight other than what we see in the media or preprints in the New England Journal about vaccine development?
Yeah, I mean, it seems like there's some promising candidates. Some of you may be involved with this work, I don't know, but Seattle's really going to be one of the centers of this globally through coordinating some of the vaccine trials. I think nothing has moved. I've never seen the scientific establishment move this fast and focus on a single problem ever. Like this even exceeds HIV in terms of the speed and focus in any way, shape, or form, both from the treatment and the prevention and vaccine work. Yeah, I mean, the optimism right now is high. There's a bunch of candidates that are gonna, they're moving so fast through phase 1 and moving into phase 2 that we're going to be testing people. I mean, people are getting vaccinated now, right? And they're going to be large trials, tens of thousands of people in the coming months, which is again unprecedented. So yeah, that's great. So I'm very excited about that. The flip side to that, and I don't mean to be a downer, is that I've got people who are PCR positive and symptomatic with COVID-19 back in March who are currently antibody negative, months out. And so I am a little, and this is not uncommon. We see this actually pretty often with a really sensitive antibody assay. And so I worry a little bit about durability. Natural infection doesn't, lead to long-lasting immunity, at least measured by commercial assays, recognizing that those, lots of other things, hepatitis B and other things, you can't detect the level of antibodies you need, MMR, similar in commercial assays. So maybe I'm hoping that's the case. But we'll see. I think a larger issue behind that as well is just this. We're kind of bringing 2 epidemics together, right? With COVID-19 and misinformation, disinformation, and anti-vaccination perspectives, which are already well heated up. And so for this vaccine to work, we're going to need high uptake. We're going to need access and uptake by the same communities that aren't getting access to testing right now, and those communities need to get actually vaccinated preferentially. And so there's a lot to be done.
So
Anybody
the
else? Go ahead,
the only
Mary.
other thought is in the fall when flu starts, it's really hard to know whether or not your patient has flu or COVID. So
Yep. Totally right. And so what I'm hoping is that we will have some sort of combination assays. So right now, like in UW medicine hospitals and clinics, we do a combo influenza RSV PCR. And I'm hoping that we'll have something similar, like a flu RSV COVID, SARS-CoV-2 assay or something similar. But you're absolutely right. It's going to be extremely hard if we have a bad flu season or even a moderate flu season that brings a lot of people with respiratory symptoms. And so when you think about a hospital, what happens when 20% or more, 30% of the beds are people in precautions, and you need to test all of them, and all the healthcare workers need to be wearing PPE going in and out. You're thinking about PPE burn rate, space. How do you take care of, your other patients when you have that burden in your facility? So that's the way, that's my job. That's what I spend all my time thinking about, is what happens in that scenario to continue to provide care how can you provide care in your clinic if someone has the sniffles and you don't know whether it's regular old human coronavirus, it's flu, or it's SARS-CoV-2, right? And that's happening,
Right.
and that's happens a lot in the flu season.
Right.
That's a big problem.
Right. So are we just going to give, everyone Tamiflu in hopes that, well, maybe if it's flu, that might work? Because, I mean, it's not like we're going to be doing NP swabs in our office. We don't have, as a small clinic, we don't have the resources.
I don't have an answer for you. I don't think it's
I know.
Tamiflu.
I know.
John,
Yeah.
why did previous coronaviruses like MERS or COVID-1, I guess, whatever, I forget the terminology, why
Yeah.
did they burn themselves out without causing a worldwide pandemic? What's different about this virus?
Well, I think what's different is that what's really interesting is the mortality rates are very different for MERS and SARS. And so they have very high mortality rates. So SARS-CoV is 10% mortality rate. But 8,000 people were infected total and 800 people died. And pretty much if you had SARS, you had symptoms, you were sick. MERS is very similar. It's a 30% mortality rate, much higher rate of mortality. And again, if you have MERS, you have symptoms. And there have been global outbreaks. So South Korea had a huge outbreak from a single person in the healthcare system, which almost shut down the healthcare system in Seoul a number of years ago. Huge. If you ever get a chance to read about it, it's fascinating. But one person came from Saudi Arabia with a respiratory illness, was undetected, was boarding, ER, went to a couple of ERs, was boarding before they made the diagnosis and infected hundreds of people, and it led to a number of deaths. So we have had big outbreaks of MERS as well. But what's the difference is that people with SARS-1, not technically called that yet, but the first SARS and MERS is that you have symptoms almost pretty much 100% of the time, and you tend to get very, very sick. So it's easy to identify you, and because you're sick, you tend to, in precautions. And so the response to both of those outbreaks have been very effective. The challenge with SARS-CoV-2 is that it's a huge spectrum of symptoms. A lot of people have an asymptomatic phase or pre-symptomatic phase, and again, I could spend an hour or more talking about those terms. But people can have minimal symptoms and be infectious. And that is significantly problematic, as I think Dr. Lasley pointed out, right? It's headache, just not feeling great. Some people don't even recall any symptoms. And that is a big problem because I can't identify who has SARS-CoV-2 unless I test them.
Well, I mean, did those other viruses disappear from mankind, or are they still?
SARS, no, there's probably SARS. The first SARS is probably out in animals someplace. It's still out there, and MERS is still pops up in the Arabian Peninsula. It's still there. It's just that it's mostly confined to some agricultural workers and some healthcare exposures. But because people get symptoms, they tend to be noticed.
Anybody else with questions? We don't usually get such expertise for free. And again, thank you, John, for getting up early and leading this effort and sending out like weekly emails to all of us on the faculty of what's going on. Nothing in my life has ever upended things like this.
No, I hope never again. But thank you for everything everyone on this call is doing.
John,
I recognize, providing patient care is, as important, if not more important than ever. And it is complicated and hard. So thank you.
We had another question.
John, how effective are negative pressure rooms in preventing transmission?
So I don't think they're that important. I'm a little controversial here. And again, this one could take hours. This is a little aerosol conversation. If you look at people's respiratory viral loads, unlike SARS, the first SARS and MERS, viral loads drop actually pretty fast after the start of symptoms. So the highest viral loads are right around the time of symptoms, just before and just after, day before, day after, maybe day two. But within pretty much a week, 8 days, 9 days, it's pretty much down to zero. So for people who are in the hospital due to COVID-19, by the time they require medical care, there's actually very little virus there. And honestly, this whole emphasis on, negative pressure and N95s, again, I don't have all the data, but I think is unnecessary. Now, we do it because we know that aerosol generating procedures in other respiratory tract infections are associated with a higher risk of transmission of respiratory viruses. But we actually don't have that data for SARS-CoV-2, and we don't have data on the effectiveness of either N95s or negative pressure to prevent that risk or to decrease that risk, which is interesting.
So John, do you think in November we're going to restart? We have one more summer session, and I projected restarting our usual teaching series November 3rd, which my daughter pointed out to me is election day. So that's a different issue. I don't know if anybody wants to weigh in that they want to hide in a bunker on that day or something instead of going to journal club. But you think we're going to be able to congregate in a room by November 3rd with social distancing?
Maybe like 5 or 10 people.
Okay.
I mean, right now we have small groups, 5 or 10 people, maximally socially distanced. But I would, for now, for large group gatherings, I mean, you tend to have a lot of people at these meetings. I would focus on Zoom this year. I mean, I think that everyone sort of wants to know, like, how soon. I'm like, to be honest, I'm just planning for a year of kind
It's
of.
pretty obvious by loosening up what's happened to us and other states are just off the charts with.
Yeah.
spreading.
And I'll be clear, the governor and our health officer in King County are moving backwards in phases in our phases in King County is on the table.
Yeah, makes sense.
Yeah. So I mean, I'm not, that's why, going back to the question about schools and November, like, yeah, I don't think we're anywhere near that yet. So my mental model is, let's get through the winter and then we'll talk.
All right. So again, colleagues who are on the line, we have one more summer series next week. Another UW faculty, Dr. Gardner, rheumatology, and then we'll take a 3-month break. And I don't know where any of us will be in 3 months, but we'll have John back again if he's willing at some time in the next year. And who can predict?
Yep.
Thank you very much.
Okay. Take care,
Thanks,
everyone.
John.
Bye-bye.
Thank you. I love you.